Okay, so welcome back, everyone. I'm going to move on swiftly to mental health now in the workplace. So we're just going to look at some of the common mental health conditions, signs and symptoms, and we'll discuss some of the things we can do to help people that we identify with those mental health conditions. After that, we're going to look at suicide, and then finally end on the day on liberty protection safeguards. So what is mental health? So we've covered this quite a few times throughout our training. The World Health Organization describes it as a state of well-being in which every individual realizes his or own potential, can cope with normal stresses of life, and can work productively and fruitfully, and is able to make contributions to his or her community. So we're looking there for a sense of health and well-being. Mental health is a state where individuals think emotional and behaviours disrupt their ability to work productively and fruitfully, and reduces their ability to contribute to their community. This ability may be impaired to a mild, moderate, or severe level. So it's worthwhile us knowing that mental health runs on those three levels. We can have mild mental health, moderate mental health, or severe mental health. So we've got that spectrum there to think about. So looking at some common mental health conditions, so these are the ones that you should all be aware of. We've got depression, generalized anxiety disorder, panic attacks, OCD or obsessive compulsive disorder, and PTSD, post-traumatic stress disorder. And that's from the National Institute of Clinical Excellence. So we've already said before in our dementia training, our role within our practice is to reduce stigma. So trying to reduce barriers, open up discussions, and to reduce stigma. So when we're thinking about reducing stigma with mental health, the stigma of poor mental health can be reduced if we stop judging those who live with it. By the same token, if someone else is offensive towards an individual with poor mental health, don't judge the offender, educate them. So what we're saying here is, if you hear people using derogatory terms, rather than having a go at them or trying to tackle them, just try to educate them and get them to kind of be sympathetic and empathetic and make them feel what we're feeling. We've covered stress already. This is to the degree to which we feel overwhelmed or unable to cope with the result of pressures that become unmanageable. We've already talked about the flight or fight response. We have the freeze response as well. And the freeze response is where we hold our breaths, breathing becomes shallow, and we start to hold it all in. We've covered stress already. I'm not going to cover that again just because we've got a lot to cover. Right. So, common mental health conditions. We're going to look at what they are, contributing risk factors, how you recognise them, and possible impacts to the individuals and others. So the first one then we're going to look at is depression. So depression is where a person experiences the emotional or negative helplessness, anxiety, or hopelessness feelings stay with them for an extended period. Risk factors to depression. So there's no single cause for depression, whilst there are lots of factors that can increase it. These can include family history, personality traits. So when we talk about personality, we're talking about people's personalities, so their behaviours, their values, and their belief system. So that's what we mean by that. Loneliness, and we've seen that loneliness, especially over the COVID period, can cause depression. Use of alcohol and drugs, because obviously that alters our mental state. Illness or injuries, reducing those levels of helplessness, or an experience of significant life event. So all risk factors there. And when we talk about mental health, we normally talk about risk factors, and we can also talk about protective factors, and we'll talk about protective factors later. But at the moment, that's what we're looking at, which makes somebody more at risk for depression. Recognising depression, we're looking at periods of low mood or sadness. Nice guidelines state that you need to be of low mood for at least 2 weeks. Okay, so we all have times in our life where we're happy and we're sad, and it's okay to be happy and sad. It's the prolonged period of time, which is suggested to be 2 weeks. Feelings about being anxious or worried, being irritable or intolerant, feelings of guilt, feelings of hopelessness and helplessness, or finding it hard to make decisions. So that's how we recognise it, the signs and symptoms. Equally, if we were going to then assess that, we would do the GLAD assessment scale. So we'd look at our assessment tools, and that's where we do the screening questionnaire. Generalized anxiety disorder. So this is where we become anxious and we have worries. So anxiety is the feeling of uneasiness, such as fear. It can be mild to severe. Everyone at some point in their life will have anxiety or feel anxious. Some individuals, controlling these feelings can be difficult. Their anxiety is constant and can affect their normal daily lives. So when we talk about anxiety disorders, we can be talking about an array of disorders. So that's things like claustrophobia, agoraphobia, so the fear of enclosed space or open space. Phobias come under anxiety disorders, so fear of spiders, snakes. So it's all of that irrational behavior that makes us worried. All of that goes under anxiety disorders. So risk factors here, again, generalized anxiety disorders have no known contributing factors, but there are some risk factors. So traumatic event, so that can cause fear, and fear causes the anxiety. The brain related to the emotional behavior, genetics, or an imbalance of brain chemicals related to mood. So when we talk about an imbalance of chemicals in the brain, we're talking about serotonin levels. Okay, so that's what we're looking at there. Recognizing them, we're looking at individuals may experience dizziness, palpitations, shortness of breath, excessive sweating, feeling sick, pins and needles, trembling or shaking. So they're normal signs of your panic attack. So that's what we're looking at there. Panic disorders. So a panic disorder is when we experience the emotions of negative, helplessness, anxiety, or hopelessness. These feelings stay with them for an extended period. Risk factors. Doctors can't say for sure what causes panic disorders, but they most think this is caused by a combination of factors, experience of bereavement, trauma, or abuse. So again, linking it back to those generalized anxiety disorders. Having a family history of the condition also puts somebody more at risk. And there is that theory around projection. So if you've been around somebody that has panic attacks, you may project onto you, or again, another chemical imbalance of the brain there. Recognizing those, then looking at anxiety, constantly being anxious, panic attacks. So panic attacks is where we're breathing in too much oxygen, not producing enough carbon dioxide. So we're over carbon dioxide in the body. So again, sitting something down, brown paper bag. Hyperventilations. So again, constant rapid breathing. Dizziness and feeling faint or lightheaded due to the lack of oxygen and carbon dioxide levels. Feeling hot and sweaty. Pains in the chest, shaking and trembling. OCD, so obsessive compulsive disorder, again, is an anxiety disorder where the individual has more than one obsession to cope with. They develop compulsions which can be seen to form rituals. And rituals tend to be the problem with OCD because rituals really do impact on people's health and well-being. So, for example, somebody may need to touch a wall 50 times before they leave a house. So that would be seen as a ritual. Risk factors then. The cause of OCDs are not yet known. However, the theories of some may develop OCDs are similar to contributing factors of mental health issues. So again, chemical imbalance. We're looking at serotonin and dopamine in the brain. Genetics, previous traumatic experiences, so PTSD, stress, and or infections. And then risk factors there: continuous of low moods and sadness, feeling anxious or worried, feeling irritable and intolerant, feelings of guilt, feelings of hopelessness and helplessness, and finding it difficult to make decisions. So again, you can see a theme here around signs and symptoms. And this is why the majority of people with mental health get misdiagnosed, because a lot of the signs and symptoms are the same for a lot of the disorders. So building that bigger picture of somebody's health and well-being is really important. Looking at PTSD, so post-traumatic stress disorder, this is often when the experience of a traumatic event will be experiencing upsetting thoughts or disturbing sleep, for example, for more than 4 weeks have passed, or their symptoms, particularly concerned the individual may have PTSD. So what we're saying there is, if you've had an incident 4 weeks ago and it's still affecting you, then there's a possibility for PTSD there. Risk factors there then, so again, gathering that history about what's happened to somebody, so experiencing or witnessing extreme violence, experiencing sexual assault, involvement in an event such as a severe car accident or a traumatic birth. There's lots of theories there around traumatic births, and that can store things in the memory. And when people do psychotherapy and treatment, some of that does come out. So it is definitely worth going back to birth related to PTSD. Recognizing PTSD, it's when the individual experiences the traumatic event. However, this won't always be the cause. Individuals with PTSD may experience flashbacks. So a flashback can be a visual flashback, so they hallucinate something, or they get a very strong image in their mind, so they can almost see the event unfold. Or alternatively, it could be through sound, or it could be a touch. So a flashback could be anything that reminds somebody of that situation. Avoidance, so if they're trying to avoid the whole situation because also reminds them of something. Emotional numbing, so trying to shut everything down and not face it, or hyper-arousal. So again, if they're being hypersensitive around smells, sounds, etc., can also trigger those. So from a health and social care perspective, we need you to look at kind of helpful coping strategies. And coping strategies is what you're probably going to write in care plans. And these can be seen as nursing interventions, so the things that you can recommend to somebody if you've got a common mental health condition there. So helpful coping strategies you can look at. What helpful coping strategies are you aware of? Okay, so if we think about here substance misuse, self-harm and eating disorders, what coping strategies do you think you can have for substance misuse? So for people that maybe drink or take substances, what coping strategies could we use for them? What might you say to somebody who's got a drinking problem? Or
explain to them the risks of this, can make it worse.
Okay, so yes, it's psychoeducation, talking to them about the problem and then getting them to identify the risk. That could be one strategy. What else could we do as a strategy? What might you say to the people that you look after if they want to drink and yet you know they've got a history of alcohol abuse? You've got things like substitutes, offer an alternative. You could have distraction techniques. So substance misuse, this constitutes the misuse of any alterating substances of the severity affecting the people's or the person's physical and mental health, social situation and responsibility. So any substance misuse is something that we're looking to alter the mind. So again, what we need to be looking at is why somebody's taking substance in the first place. So not labeling them, not judging them, not calling it a problem, or using the term alcoholic or negative terms. We avoid all of those things. And it's useful to look at what we've got around us, so our social prescribing skills. So do we have networking? Are there charities in which we can do referrals? If we haven't got that and we're having to face it, then distraction techniques. So maybe talking to us, maybe offering a replacement. So if they want an alcoholic drink, maybe offering them an alcohol-free drink. So again, with smoking or substances there, looking at nicotine patches or sensation stuff. Coffee can be seen as a substance because it has an altering effect on our physiological state. If we drink too much coffee, then we can tend to go on to decaf. So what we need to be doing within our services, within the people we look after, we just need to be thinking about those alternatives and substitutes in which we can offer. When we look at different types of substances, we're looking at obviously alcohol, recreational drugs, so things like cannabis or legal or now illegal highs, prescription medication, so pain relief, opioids and things like that, glue, solvent-based stuff, aerosols, cigarettes, coffee, and food. So food can be seen as a substance misuse because obviously it's an item that we can control our body with. So we can either overeat or we can be purging that causes the bulimia. How would you know if somebody is substance misusing with aerosols? What would be the telltale signs? Do we know? How does somebody inhale or take aerosol? So things like deodorants and things. Idea. So aerosols are normally sniffed. So what you would normally be seeing is kind of burn marks and blisterings around the nose or mouth. General giveaway. Cracked lips could be a sign. If we were to do a neurological assessment, so if we were to shine the torch in the eyes, we'd be looking at the dilations of the pupils. So if we've got slow reacting pupil dilation, it would probably be an indication of a substance misuse. In your services, depending on the type of service you're in, you may have screening drug test kits. So where you do a sample through the urine, you can tell if somebody's on substances, or alternatively, you may have things like, for example, for the alcohol, breathalyzers, etc. So thinking about substance misuse, if you're using that as part of your service or the people that you're looking after, you'd obviously have your care plan there, you'd have your items to swap it with. With alcohol, if you've got somebody that's been on alcohol for a prolonged period of time, we've got the alcohol screening tools. So in our paperwork, you've got the alcohol misuse chart. It's a questionnaire. It tells you how much they're drinking and whether or not they're drinking too much. Part of alcohol reduction is the fact that we wouldn't stop somebody who's an alcoholic. We would still allow them to drink, because if you stop somebody drinking alcohol, it can be deadly. If you all remember Amy Winehouse, the singer, she died through alcohol-related problems where she was drinking a litre of vodka a night. She went into rehab, she came out, she started drinking again, and she was drinking for a prolonged period of time, and then she just stopped overnight. The problem is the body went into shock and it killed her. So if our body relies on that substance, we would never stop it. We do a slow withdrawal. And again, there's lots of work for the NHS to work with care homes and nursing homes, do rehabilitation. There's a drug, I think it's called Campril. Campril is a drug which helps with the substance misuse, so the withdrawal, so it helps with the tremors and the shake, and it helps as that substitute replacement. So there's lots of things we can do to help people with substance misuse. And obviously, the way to go forward really is that open dialogue, having those discussions about what it is they're doing, and then looking at the right support mechanisms. Again, if you know somebody that's got a substance misuse problem, or you suspect, the people you're looking after have got those problems, obviously being non-judgmental, writing a care plan, look at safe withdrawal method and alternative and distraction techniques. Long-term impacts for people on substance misuse, obviously poor productivity, increased sickness levels, social withdrawal, financial concerns, pressure on relationship, increase of risk of mental health or mental health conditions. So the longer we're on substances, the more it can cause psychosis and hallucinations, increased risk of physical health problems. So we know that our liver and kidneys are our cleansing organs. So again, we tend to end up with liver or kidney functions, and an increase of likelihood of dependency on more harmful substances. So once they're not getting the kick in which they originally needed from the substance, they tend to turn to more harmful substances. So actually quite a lot of long-term impacts there to think about. So recognizing somebody who's on a substance misuse, evidence of impact on productivity or relationship. So what we tend to say, if we're talking to somebody, the way that we would in our minds diagnose this as a problem, if it affects their relationship, if it affects them financially, or if it affects their health and well-being, then it's normally a substance misuse problem. Okay, so that's what we would describe as a substance misuse. The other one that's not on there is gaming, so the younger generation in gaming, so people that are addicted to their phones and computers as well. So changes in their physical appearance, so if they're putting the substance before their own personal care, so you can generally see people declining in the way that they look, in the way that they care for themselves, because they no longer really care. They're intoxicated at inappropriate time. Now, we need to be mindful about what inappropriate times are, because we work all around the clock. We work a 24-hour day. So if you had a glass of wine in the morning because you've done a night shift, to me, that's not an inappropriate time. That's your bedtime, and you probably deserve that glass of wine if you've been on a night shift. It doesn't make you an alcoholic. In an inappropriate time would be maybe turn up for a job interview or going to the bank or something, and you were under the influence of a substance. Mood swings. So we know that substances change our mood. So if we almost get this bipolar effect, so we're happy one minute, sad the next. Physical injuries. So if we've got a history of falls, that could be an indication of substance misuse. Evidence of substances and evidence of, and I can't say that last word, again, respiratory problems or other health conditions. Possible signs of individual substance misuse. Oh, no, I've done that one. So getting help. So this is the stuff that you're going to be looking at for your social prescribing side. So things for you to say to somebody, you know, you're not in it on your own. There's lots of places you can go. You've got Frank, Alcohol Anonymous, Narcotics Anonymous. So depending on what you think is the concern. Reality is, if somebody has a substance misuse problem, they're probably masking other deep emotional problems. What you tend to find with substance misuse is it's their coping mechanism, no different to people who self-harm. It's a behavior in which they're trying to deal with life. Normally, when you talk to somebody who's got substance misuse, they tend to have quite deep, dramatic stories in which they want to share. It's really our job to get onto that level, to try and support somebody to understand why they've got to where they've got to. So just talking to them, saying, look, I can see that this is distressing you, I can see this is upsetting you, or I can see that this is causing you a problem. Do you want to tell me, you know, where this all started? Our kind of skills in our nursing realm here is those 7 whys. So keep digging, root cause analysis, keep digging, keep asking why as much as you can, on the grounds that they're prepared to talk to you. Because for them, what they may be facing is all of their behavior. So with substances, it obviously affects the people around them quite a lot. So trying to help them to come to terms with some of that stuff is really important. So it's all that non-judgmental stuff that you need to be working on. Any questions on substance misuse? No. So top takeaways then, don't stop the behavior. That's not your job. We don't want them to stop, because actually we've already said if they stop, they could go on to something else. So you helping somebody stop may not be the right thing to do. The right thing to do is be non-judgmental, refer them to the right point. And if you are part of a treatment plan, so if you have got somebody that has a substance misuse, then hopefully they would have been prescribed an alternative substance to manage the chemical imbalance that's going to be created within the body. And remember, substance misuse, there's going to be a lot of emotional stuff beyond that. That's generally the top of the iceberg. Okay, eating disorders. So an eating disorder is simply an unhealthy attitude towards food, which can take over an individual's life and make them feel ill. So an eating disorder isn't just about the anorexia, it can be overweight as well as underweight. What is the assessment tool for weights?
Must.
Must, wonderful. So we do our must score, and actually our must score is going to tell us a lot. There's 3 types of eating disorders. We've got anorexia, so that's obviously the complete weight loss, where we go down to that really, really unhealthy thin weight. We've got binge eating, so that's that uncontrollable eating, and again, it's a substance. That's what we're using it for. Or bulimia, so that's where we get the purging, where we eat and purge. It affects around 1.25 million people in the UK, which 11% are male. So again, it affects both male and female. Obviously, it affects females more. Why do we think it's more common in women than men?
Figure conscious.
Yeah, women are definitely much more figure conscious than men. It's that ideology of social media, isn't it? That women have to look in a certain particular way, and therefore there's this upkeep. So you need to be able to recognise and respond to all 3 disorders. So anorexia is a condition where the individual loses their body weight. It can be controlled by under-eating or over-exercising. Now, I've seen this in both ways on a ward. I've seen a young girl completely refuse to eat. She was barely doing a glass of water a day. And then I've seen another girl who ate, very, very minuscule, but was then running up and down the ward. So she was burning more calories than what she'd got going in. So again, look for that behaviour. Equally, look for the purge as well. So if you suspect somebody to have an eating disorder, you tend to see lots of behaviour around it. So they become quite aggressive. They don't want to sit down at the meal table with you. They don't want to eat in front of you. What you might see is if you've managed to get them to the table, that they run off and then purge, so that they're trying to be sick. It's the individual believes that they've got a problem with their physical appearance. So that's the problem there. Commonly starts in early 20s, involves eating. Oh, hang on. No, we've skipped one. It has none of the symptoms there. Yeah. So anorexia, then, we would obviously do our must scores. Our care plan is going to be looking at a fortified diet. So it may be the fact that the stomach isn't used to eating food, and therefore we'll do the milkshakes and the build-up drinks slowly. And equally, we would reduce all exercise. So we would keep somebody on quite close one-to-one observations. You'd obviously have the referral from the dietitian and the mental health service team. A lot about the anorexia is keeping them under control. The sad part of anorexia is when it turns to extended feeding techniques. So when you end up with the nasal feeding tubes and stuff like that, so it can become really distressing. So signs and symptoms there, then you've obviously got the extreme weight loss, you've got the change of behaviour and mood, you've got the defensiveness around, and you've probably got some body dysmorphia going on, that whole low self-opinion of themselves. Binge eating commonly starts in early 20s, involves eating to excess. Binge eating often because people feel guilty or ashamed. and the condition doesn't always lead to significant weight gain. So why do we think this happens to people in their early 20s? What's happening to us in our early 20s? You can have mental health conditions. What was you all doing in your early 20s? Would you start in new jobs, maybe looking at new relationships, starting a new life, trying to leave home? And actually, when you think about all of that, it's really stressful, isn't it? Really stressful. So again, it's not surprisingly that people in their early 20s go through this kind of roller coaster of emotions. So again, we can look at food as a substance. So people in their 20s tend to be quite party animals. They go out to university, studying, exams, and all of that higher education stuff as well. So lots of reasons there for why people may binge eat. And then bulimia then. So like anorexia, bulimia is a condition where the individual tries to keep their body weight as low as possible. The individual eats to excess, but then purges by vomiting. After the binge, the individual feels guilty and then ashamed. So this is the embarrassment about what they do. The condition doesn't always lead to significant weight gain, because obviously the whole point of that is purging. So with bulimia, I've seen it a lot more in younger girls that are probably size 18, 20. So they're generally a bit bigger girls than what you would normally see. Obviously for the thin ladies, and they tend to just binge and purge because of that feeling of guilt and ashamedness. So just because somebody may look slightly bigger does not mean that they haven't got an eating disorder. So again, don't just assume that you have to be thin to have that eating disorder. So common contributing factors, obviously for eating disorders, genetics, changes to the brain chemistry. So again, a lot of the eating disorders are in the younger generation. So from the 16, the youngest person that I've dealt with was 14. There are younger than that, but very, very uncommon in young children. Normally 14 up to about 24. So when we think about that, that's a lot of puberty and hormone changing going on there as well, isn't it? It's a lot about body identifying and stuff there. Occupational pressures. So there was a recent thing in Emirates Airline where the staff have been weighed and shamed. So again, you know, if you work in an industry as an air hostess, you have to be this certain figure or a model. That's your occupational pressures. Social pressures, I think that's probably more to blame. So looking at those unhealthy images of people that's on the internet and this body perfect thing, and filters, I think filters have a lot to answer for at the moment. Then cultural expectations. So again, what your family or your past families say should be. So eating disorders then, depending on the type of eating disorder, you may see different related things here, but we're looking for unhealthy relationships with food. So we're looking for changes in the amount of food that they start to eat, either eating too much or too little, constantly weighing themselves. So it's a thing that's quite important to them. You may see them hiding food or squirreling food away. They may leave the table after eating, possibly to purge, so they go quickly to the toilet. They could be over-exercising, so they're deliberately burning more calories than necessary. Avoidance of eating around other people, so if you've never really seen somebody eat, that's something to be thinking about. Or they may constantly be feeling cold and lightheaded, because obviously the body requires a certain amount of fuel for the body to keep us warm. So again, getting help, lots of refer on for this, lots of kind of social prescribing here. So GP therapy services, normally talking therapy for eating disorders. is linked to CBT. So there is cognitive behavior therapy for eating disorders because it's the thoughts and feelings relating to food. And there's some charities there. Ultimately, in a care service, you may have extreme exposure therapy. There may be a relationship training with food. Or again, you may see things like fortified diets, those milkshakes, and then other things there. Any questions on eating disorders? Happy with that? Okay, self-harm. So self-harm is the intention of harming or injuring oneself. Self-harm is a coping mechanism for the individual to manage their distress, thoughts, and feelings. So, types of self-harm include burning, cutting, poisoning, biting, hair pulling, use of a ligature, so that's tying something around the neck, over or under eating to cause pain on the body, over exercising is seen as a self-harm, or head banging. Okay, so lots of different types of self-harm there. The effects of self-harm could include fractures, injuries to the nervous system, blood vessels or muscles, permanent weakness or numbness of certain areas, multiple organ damage, so again, normally liver, kidneys, infection to the injury site, so you've got infection and sepsis, social isolation, poor interaction, because again, that mechanism shuts down people not wanting to show your body to people, increased feeling of shame and disgust or guilt, especially if they're being told what they're doing is selfish, because that then just adds to the problem. Or self-esteem and self-image. So again, if somebody's body conscious, it's something to be wary of. Permanent scarring. I've seen lots of poorly healed scars through self-harm. Suicidal thoughts and behaviours, we'll go back to that, because just because they have suicidal thought doesn't mean that they're going to act on them. They're just thoughts at this point. Or accidental death. So accidental death is they've cut themselves too deep. So ways of recognising self-harm then, and it can be difficult because obviously it's a hidden behaviour. Again, we're looking at a person in a holistic way, and doing this, we're looking for evidence of injuries such as cuts or bruises, things that they can't explain, or maybe the story that they're giving to you just doesn't add up. So, you know, they've got lots of cuts, but they're saying the cats scratched them, and actually it's not like a cat scratch. Wearing inappropriate clothing. So if it's a hot day, it may be like they're wearing trousers because they're cutting the top to their legs, or if they're cutting the top to their arms, they're trying to cover things up. Regular time off of activities, so it could be school, college, or work. Then obviously blood on bed sheets or clothing. So just looking for obvious signs of a bleed there. Getting help for people with self-harm. First aid, so obviously if somebody has injured themselves, we're going to go back to our primary survey and secondary survey, making sure airways is done first. We'll then look at obviously treatment, so breathing, bones, so we'll deal with any bleeds, and we'll deal with any breathing problems first. If it's respiratory poisoning or a ligature, we'll cut that off. Then we deal with the bleeds, then we deal with any broken bones. We may need to get them to an accident emergency department. Obviously, they should be talking to their GP because there's signs of depression and maybe anxiety there that we can support them with. There are some charities there around self-harm. There are lots of things that you can support people with self-harm. So equally giving advice and guidance, talking about their techniques, what they're doing, talking about septic, you know, if you're going to cut yourself, have you got the cleaning equipment? Are you using a clean blade? You know, all of this advice, non-judgmental. There is some CBT therapy there, so there's self-help guides as well for self-harm. And equally, there's different strategies. So there's things such as using a red pen, drawing on yourself rather than cutting. There's a theory about using ice cubes to cause that sensation of a cut, so using an ice cube. Alternatively, there's like the elastic band approach where they can just ping themselves with an elastic band rather than cutting. All of the self-harm stuff can be quite distressing. So again, if you have got somebody self-harming or you're managing someone that's self-harming, just be mindful that you don't respond, keep it, keep that non-judgmental face, offer the emotional support. And with first aid, don't necessarily go in and help them straight away. Ask them ask them, can you help them? Or do they just need a first aid kit to sort themselves out? From a wound care point, we obviously know the sooner we can close that wound, less likely it is for scarring. So that's where we need to be. And equally, if you are seeing somebody cutting in near the wrists or up by the neck, we need to give that advice and guidance to steer clear of arterial lines, because again, that ends up in the accidental suicide front. And there's loads of support online for self-help around self-harm. What is important is to try and limit the restriction of negative images. So online, there are lots of images of self-harm, and that can be quite harmful. And there's lots of sites which goad people on to do it, and they tell them different techniques. So again, just be mindful that if somebody is self-harming, try and have that conversation with them. So, have you seen anything online? Because it may be that social media, people are telling them to do it as well. Any questions around self-harm? No? Okay, so supporting people with mental health conditions, you've got the 4 E's here. You need to think about the environment in which you're in. So if you're going to have that conversation with somebody, make sure you're in a good environment where obviously you're not going to be overheard. It's about effective communication. It's in the order of priorities, so 2 eyes, 2 ears, and 1 mouth, to kind of use it in that order. Tell them what you're seeing, more of the hearing than the talking. And the best way to support somebody with mental health is by just saying what you see. I can see you're upset. I can see you're distressed. I can see you're angry. What's going on? Tell me. Because it shows that you're looking, and it shows that you're caring and you're trying to help them. Once they start talking, use the empathy approach. It must be difficult for you. How's it affecting you? And go back to Davis's interview techniques. What's the most important thing I can do for you now? How can I help you now? Engage is all about that crisis plan. So when somebody's with you, what is it we're going to do to help reduce this in the future? So how can we help with these symptoms of mental health? And in a crisis plan, we can look at an array of tasks. It could be the fact that you use distraction technique. It could be the fact that you use self-help. It could be the fact that you use apps. It could be the fact that you've got counselling. It could be the fact that you've got a mantra, so something that you say to yourself over and over again. It could be the fact that you've got a safety place or somewhere where you go to maintain your thoughts. So what we would normally do with somebody is create a safety plan or a crisis plan. And that safety plan and crisis plan, again, is in your tools and stuff. Mind and Rethink, if you Google Mind and Rethink, they have safety plans and crisis plans. And they do cards that you can download, and it goes in the person's wallet. What we're trying to do with mental health in the workplace is say to people, the moment you recognise that something's going on, pull out your safety plan, pull out your crisis card, and when your thoughts are a little bit disturbed, follow that and it will tell you what to do and where to go. Signposting is really important. So again, we've looked at those positions: signpost, GP, online, and other areas. So let's just have a conversation here then. So Nigel is an 18-year-old chef in a London restaurant. She travels to work each day on train from Southend for about 2 hours long door-to-door journey. Nadia has started to appear more unfocused at work and increasingly late in the morning. you're aware of Nadia is a mother. So what would we be thinking here about Nadia? How could we approach Nadia in this situation? And obviously it says here, self-employed has a higher than average unemployment rate. So, and teen pregnancy. So what would we be thinking about Nadia?
We can talk to her and ask her if we can help her in any way.
Okay, so how would you start that conversation?
I will ask her if it's something that bothers her or concerns her or something.
Okay. Anyone else?
Maybe she needs somebody to talk to, or she needs somebody to listen for her problems.
Yeah. So again, if we use our observational skills, we can say, hi Nadia, look, I can see that this is a long journey for you, and I can see you've been late a couple of times. Is there anything you want to tell me? You know, can I help you with anything? Let's just be upfront. Let's not beat about the bush. This is what the evidence is. Let's just talk about that. Because she may become really defensive, and that would give you an indication, you know, is she avoiding you? Is there something going on? We could say to her, look, Nadia, I can see that your appearance, you don't look the way you normally do. You seem a bit unfocused. And she might be saying, oh, you know what? I'm a new mum. I've recently had this baby and I've got a lot going on. So what might we be thinking if she's starting to self-neglect and she seems a bit, you know, unfocused and she seems a bit low in mood? What might we be thinking?
She's stressed.
Yeah, absolutely. We've got signs of stress there, haven't we? Because there's that like visual bits there. Equally, that 2-hour door-to-door journey. So that's quite a trek, isn't it? So, you know, is there financial problems going on here? So we can then start to look at our Maslow's hierarchy of needs, can't we? We can start to support her through some of that stress stuff. Like, Nadia, you're only 18. Did you know that there's a loyalty card or a travel card for you that probably reduce the cost of your travel? Or are you getting all your benefits for your entitlement? You look tired. Have you thought about some sleep hygiene practicing, or have you thought about some relaxation stuff? So this is all the advice and stuff we can give. If we had to do a refer on, who would we ask her to go and speak to?
Therapy.
Yeah,
Maybe.
therapy. We could ask her to go speak to her doctor and get a referral, you know, and we can normalize that, can't we? We've all been 18. We've all burnt the candle both ends. We've all been in that situation, haven't we? Where we've done long travels to work and we're all thinking, God, why are we doing this? So we can normalize some of that and go, look, I know this is hard. I had a similar experience. I know how I felt at the time. Are you feeling like this? Because if we can normalize that and we can say, look, when I was going through this, I felt exhausted and drained and I felt completely flat and empty. Is that how you feel? You know, because if we've got that suspicion, we can kind of piece it together and kind of lead her in to open up and talk to us. It could go either way, couldn't it? She could start saying she's depressed and she's feeling angry, and because if she's got that long journey and she's tired, then that's probably going to be leading into anxiety or depression, isn't it? So again, lots of things we can do there just to have those conversations. It all starts with that conversation. So when we think about empathy, it's obviously the capacity to understand how somebody feels and what another person is experiencing with the frame of reference. This is the capacity to place oneself in another person's shoes. So again, that normalizing behavior just makes me think, oh God, it's not just me, you know, we've all gone through this. And remember that levels of resilience. Some people make it look incredibly easy, life, and some people make it look quite difficult. Okay, so now Nadia is and has a 2-year-old child. Her friends are about the same age as her. Nadia says all they want to is have kids. sponge off the government. Nadia is currently living with her parents, but even though they aren't working, they won't babysit for Nadia, so she has to put her daughter into nursery. She likes the nursery as they open up at 7 a.m. and the staff are great with the kids. So here, what kind of things could we now be talking to Nadia about? What do most mums do at this point? I can say this now as a new dad as well. What do most parents do with their children? Would you agree that most parents put their children first and they self-neglect? So as long as the child's okay, I'll battle on, as long as the child's okay. So explaining to her, look, you got to look after yourself as well, because if you look after yourself, you're able to look after your children better. Looking at her story around sponging off the government gives you an idea about her values and her belief system. So you can say to her, look, this is it's admirable to say that you don't sponge off the government. Have you sat down and spoken to somebody about your benefits? Because in some ways some people are better off on the welfare system than necessarily working if she's not able to support and stuff. So maybe there's a different scheme she could go on. Maybe she could go on a reduction scheme, or maybe there's benefits around if you turn to us, they can do childcare vouchers or whatever it is. So it's about her talking about her network, because what this says to me here is she doesn't have a very good social network. Would you agree? Or do you see something different there? Do you think she's got a strong network around her? I think the only thing that I can see on that at the moment that's positive is the nursery. It opens at 7 a.m. and that probably helps because of work, doesn't it? So the reality is, just getting her to open up about has she got friends, has she got anybody else, you get a sense of what it's like to live in Nadia's world, and that's where we're trying to go. That empathy bit, isn't it? Then we can do more referring on and describing, this, have you thought about this? Have you thought about that? Okay, so effective communication, body language, voice, tone, words, open questions, active listening, empathy, and environment. And we know all of that. We've done loads around communication, haven't we? So we've seen this before, haven't we? 55% body language, voice and tone, 38%, and use of words. So equally with Nadia, we don't really need to even talk. We could just nod, agree, and just shake our heads. Okay, so moving on to suicide. This one might be a bit tricky for some people. So again, if you've had experience of suicide or suicidal thoughts, if you find it a bit too much, by all means, just take 5. But have you had thoughts of suicide? So you don't have to answer this, but has anyone in the room had thoughts of suicide? I don't mind kicking off saying I have. I've many a time sat there and thought, God, I'd be better off dead. Life's got too much, and I've sat there and gone, why am I here? What am I doing? The reason we're saying this is because it is a normal thought. We are all in our lives, we have sat down at some point and gone, in our minds, we may not have said it out loud, we have all said to ourselves in our head, I'm probably better off dead. What am I doing here? Okay. The reason we talk about this in quite an open and frank matter is because suicide is one of those things that you have to have the conversation over. You do not know what's going on in somebody's head if you do not have that conversation. We need to understand that thoughts of suicide are fine. We don't need to, yes, it may be a red flag. It's okay to have a thought of suicide. So what we need to do is use our question techniques when we're talking about suicide. And the reason we have to use opening question techniques is because NICE guidelines state you cannot use an assessment tool when it comes to suicide or self-harm. Okay, so there are no approved assessment tools for suicide or self-harm. It is called a clinical interview. And what we do through a clinical interview, we start to look at risk. Okay, so here we have to have those conversations. And the first question you have to ask somebody, if you think that they're suicidal, is this: are you suicidal? Are you thinking of killing yourself? Now, that's quite a brave conversation, not a great icebreaker. But the reason we have to ask it is because we have to be sure that they are in that place. Okay? Because if you said to me, Stephen, are you suicidal? I may go, look, I've had suicidal thoughts in the past, but I'm not suicidal. That would give you a very clear indication that I'm not planning to end my life. I'm just, I had a thought, it's gone. If, however, you go to me, Stephen, are you thinking of suicide? And I go, yes. Okay, do you want to talk about it? Tell me what you're thinking. I have to tell you what I'm thinking. If I start to give you a plan, a date, a time, a place, maybe I've a lot of thought into it, the risk is from here to up here. It's no longer a thought, it's turning into a behavior, a plan. Okay, and what we know is the moment people start to plan, that plan becomes a behavior, and we know the behavior, they start to then fulfill that behavior. That then turns to the next stage of the act of suicide. So the only way in which we can manage this situation is by, first of all, asking them, are you planning suicide? Are you planning to end your life? Quite a brave thing to ask somebody. If they're not, just going to go, no, I'm not. Nobody gets angry. If they do get angry, that's probably a red flag. Okay, so are you thinking of killing yourself? Are you thinking of ending your life? Depending on how you want to ask that question. Don't leave it ambiguous. It has to be, the first question has to be, are you thinking of harming yourself? Killing yourself, sorry. Don't say, are you thinking of harming yourself? Because again, harming is very different to ending your life. So are you thinking of ending your life? Once they've said yes, then, or no, if they say yes, then you need to start probing, what are you thinking? Tell me what your thoughts are. Because at this point, if you think they're going to do it, what we do is we do a safety plan with them. And the safety plan is you agree to keep yourself safe. You agree that you can go to A&E. You agree that you'll keep yourself safe until somebody can come to you or whatever. If they say yes, then we accept that safety plan. And we get the wheels in motion. We call the ambulance, we get somebody out to them, or we stay with them. If they say no, that they can't agree to the safety plan because they're compelled to follow their suicidal thoughts, then obviously that's when we call the police and the ambulance. And at that point, that's when they'll probably be sectioned. So there's two areas in which we can go here. The first area with suicide is, can we keep you safe? If we can keep you safe, what we tend to see with suicide is it could be a thought passes, the anxiety level drops, and they just need some aftercare. If, however, they go, no, I'm going to do it, I'm going to, I don't know, jump in front of the bus that's arriving in the next half an hour, we take that seriously. We don't say, oh, we don't think you're going to do it. You've now given me a plan, you've given me a method. Okay, so this isn't a fleeting thought, you've put thought behind it. Okay, happy with that so far? So when we talk about suicide, it's okay for them to say, I'm thinking, I've had thoughts. We need to ask them about those thoughts. How often have you had them? How long do they stay with you for? Let's get some information. Because they may say, look, it was the one. It came, it went, it was just one of those moments. Or they may say to you, I'm having the thought several times a day. Okay, so we've gone from here to here on risk, haven't we? Okay, have you got a plan? Yeah, I've got a plan. Okay, we intend to follow that plan through. Yeah. Okay, so we've gone from here to here. And the only way we're going to know this is if we ask questions. And what the evidence suggests is that most people, or there was a survey done on 100 people that have attempted suicide, 95% of the responses instant regret. Okay, so that's quite a high response rate to those that have attempted suicide that then instantly regret it. So the problem with the act of suicide is the method in which they've chosen could be quite instant. So when this survey was done, it was done on people that have obviously survived. And before people have completed the act, there was this instant regret, which basically shows even though people get to the point of suicide, they feel it's the only way out, that there's no choice. Actually, it's not what they want to do. It's the mental health, it's the compulsion to follow the plan through. And our job in this point is to break that plan, to give them a bit more thinking time to keep that clear. It was one of my biggest fears about being a mental health nurse, working with patients that were suicidal. However, what I would say this is, in my experience, all of the people that I've ever spoken to about suicide have been very open and honest about it, because they get to a point where they've got nothing to lose. So they're just going to be honest with you. It's up to you to listen to what they're telling you and not judge anything. So we don't use any language which provokes, we don't use any language which can be derogatory. We just do lots of listening, lots of, okay, thanks for sharing that. And in your head, you're thinking safety plan all the way. So once you've got them where they are, think about the safety plan and look at how you can move forward. That's some really good questions. How are you feeling today? Can you explain to me what made you feel that way? Or can you tell me about the last time you spoke to your doctor? So again, just using those open questions to get somebody talking. Their response could be open or closed. So they could say, I'm fine. That allows you to kind of pick things up. Obviously, can you explain what made you feel like this? First, I was just upset and I realized it wasn't my fault. And can you tell me about your doctor? So you can ask open and closed questions, but be mindful that you can get open and closed responses. And if you're not getting the right response, rephrase the question. Suicide, you're not just doing what you hear, you're also looking at the behavior. And for suicide, I tend to use the mental state examination, the MSE. So that is one of your assessment tools. Now, the mental state examination, as you go into those assessment tools, basically is an observation assessment. So you look at appearance, body language, mood, their effect, and what they're saying. And actually, if you use the mental state examination as a clinical interview, it's really helpful because it helps you structure talking to somebody who's suicidal. So again, looking at their appearance and their behavior, does what they're saying to you, does it marry up the words? So for example, when we look at mood and effect, I may say, I'm feeling really suicidal today. And I've got nothing. I'm feeling suicidal today. But I might go, oh my God, I'm just feeling suicidal today. You're like, oh, that's a bit weird. Or I may say, I'm feeling suicidal today. Behavior tells you a lot about what's going on. So if you've got somebody who's crying and quite hysterical, it says to me that this is an emotional response. Maybe they've got a lot going on. If they're talking to you and the effect is quite flat, so yeah, I'm feeling suicidal. It's a bit weird. It's a bit off-putting. It's a bit nervous. And if somebody's laughing and they're talking about it, again, it's a very altered behavior. So as you're talking to somebody, you're trying to pick up the body language that's going with it, because we know 55% is body language. So it's really important that we can work with that as well. Again, observation skills, look around you. Is there a weapon? Are there pills? Is there a rope? Equally, looking for those facial expressions. Are they nodding, smiling? Are they maintaining eye contact? Or are they looking down? Are they quite flat? Look at the words in which they're telling you. So the words in which they're telling you might be, so for example, I may say to you, you think you should go to your doctor? They may say to me, there's no point going to the doctor anymore. Oh, well, that seems quite a final statement. But they said, oh yeah, no, actually the doctor might help. I've got a bit of hope. That makes sense. So picking up on their responses gives you, again, a bit more gut instinct. Recapping on what they've told you is really important around suicide. So for example, if I said to you, there's no point me going to the doctor, I may then go back to you and say, oh, can I just, so what you've said to me is there's no point going to the doctor. Can I ask why? Well, I won't be around. Okay, why won't you be around? Because you'll give me final statements. The other thing to look out for is the behavior. So a lot of people that are planning suicide, their behavior automatically changes. So for example, they've been depressed for the last 2-3 months. Now all of a sudden, they seem fine. Seems really odd, like an immaculate recovery. And the reason for that is what the evidence suggests is somebody that's been depressed for a long period of time, if you give them a way out, all that depression goes, the relief goes. And the problem with that is that's odd. That behavior is incredibly odd. So if somebody is really happy who's been depressed for a long period of time, that would be a red flag. We'd be looking at that. Are you planning an end in your life? Are you looking for this way out? Is this your relief? So again, when we're talking to them, maybe you say, you know, have you got let's say it was financial troubles with Natalie, and she goes, I'm not going to have money worries anymore. Well, then all of a sudden she's relieved about it. The other thing is about possessions and properties. So some people will start to give things away, almost that living will. They're trying to pass their things over, or they're trying to say goodbye to you. So again, it's your job to listen for those statements. Okay. So a constant recap and confirming is really important. So under the environment, obviously just make sure you consider the environment, make sure you're comfortable, make sure you're in the appropriate place, make sure you've got minimal disruptions, obviously confirm the location with the individual if you're going to have a chat with them. There's a great, I don't know whether you've seen it, it's called The Man on the Bridge. It was a Channel 4 documentary, and it was about a man who was going to jump from Westminster Bridge, and it was in rush hour in the morning. And hundreds of people passed him, and he was standing on the bridge ready to jump. And I think it was a young lady went up to him and said, oh, have you seen the football score? It broke his concentration. He couldn't understand why he was being asked this random question. And what she'd done, she'd broken the cycle in his head, which was you're useless, you're worthless, jump, to tell me what's going on. Why are you standing there? Talk to me. And she managed to talk him down from the bridge. I can't remember his name. But anyway, it was called The Man That Jumped the Bridge. Or yeah, I'll get you it. I'll pop it on canvas. But basically, what evidence suggests is people that are or in the final stages of suicide, they end up in a contemplation state. Their mind is whirling with all of this stuff. And again, you just having a conversation with somebody is enough to pull them out of that state. So if you've got somebody, you know, if you've got that internal voice going around, you're useless, you're worthless, do it. Just a friendly voice saying, are you okay? Is enough to break that concentration. Okay, we've covered that. I don't know why we've gone back to that. So improving mental health and well-being. Oh, hang on, before we go there, that's into suicide. Are there any questions on suicide? It will make sense. So recap, no clinical assessment tools, it's a clinical interview. The more risks, so the more chance that they're going to do it, the more likelihood it is. And I will recap that on the children and adolescent one that we're going to see in a minute. Ultimately, we're looking for the plan and the intent. And if they've got plan and intent, red flags go up. We need to stay with them or call the ambulance. And obviously, if they agree to a safety plan, then we can obviously talk 111 and follow their safety plan. Okay. So ways to improve your mental health and well-being, obviously reduce loneliness. Social deprivation is never a good thing. There are activities, networking, social groups, good nutrition, eat your 5 a day, reduce alcohol, which again was another initiative, get more sleep. So it's called sleep hygiene. I think I've put sleep hygiene in your canvas now. So I wrote a 5-step program for sleep hygiene. So it looks at improving the way that we sleep and getting better quality sleep. Exercise, mindfulness, so distraction techniques, therapist, volunteering, stop fearing failure, and be more mental health aware. So lots of things that we can discuss with people about improving their mental health and well-being. Good nutrition. So again, water, we know roughly 2 litres, but just for normal bowel stuff. Fruit and veg, 5 portions, which we all know about. Omega-3, fish, mackerel, sardines, flax seeds, and pumpkin. Vitamin D, which is our sunshine stuff. So again, we're good for that. And again, slow release energy foods such as pulse grains, nuts and seeds, because slow release of energy keeps our GI levels up. Combating loneliness. So again, look for activities that you can do to combat loneliness. So pay more attention to the present moment, to your own thoughts and feelings, and to the world around you. So we have lots of access now to mindfulness tools. One of the apps that I rave about, because I think it's one of the best apps out there, is an app called Mood Tools. It's on all the app stores. I highly recommend everyone to download it. It got stuff in there from suicide plans to mindfulness to just some relaxation. It's got CBT, thoughts and feelings. And it's one of those apps where if you need to help somebody and you don't know what to say, you can just say, look, have you heard of Mood Tools? And it's got everything in there, including access to therapy. So it's got access to 7 Cups, which is a free counselling tool. So you can instantly start talking to people. Exercise, we know regular exercise boosts self-esteem, increases endorphins are feeling good, reduces stress levels. And finally then, so reflection then, reflection from mental health and stuff, it's really important. And for you guys, you'll use either Gibbs reflective cycles or Ralph, the so what, now what, and who what exercise. Okay. Let's just, so I'm going to move now to, I'm hoping this is suicide in children. I don't know why my computer's saying that, because that's not true. Okay, so I'm going to quickly whip through this because obviously we've just covered a lot of this. So for young people, and this is kind of really important. Young people and suicide awareness is really important. This is an information session that I've done to a couple of boroughs. So the aim of the session here is for us to understand what are suicidal feelings, what causes suicidal feelings, signs and symptoms, what to do about suicidal feelings, what will happen if I tell the doctor that I'm suicidal, supporting a friend who is suicidal and getting the right help. Okay, so suicidal feelings, it's a normal part of life to feel down and sometimes sad. But those feelings don't have to become very deep and intense. So we're talking about the intensity of the feeling. So asking somebody, you know, on a scale of 1 to 10, how bad is this? And equally, we need to know how common those suicidal thoughts are. So just getting them to talk to you about the frequency. Now, we know with anything, and again, for this analogy, I always say to you, think about something that you've wanted to buy from the shop. You can't really buy it because you haven't got the money or you don't really want it. The more you think about it, the more you want it, right? If there's something that you wanted, but you just can't buy it, the more you think about it, the more you want it, and the more you're going to do to get it. And that's the problem with suicidal thought. The more they think about it, the more it's there, the more risk goes up. So if somebody says to you that they're having thoughts all of the time, that becomes a real risk factor. So what causes suicidal feelings? Depression, other mental health illnesses, so schizophrenia, hearing voices, seeing things, substance misuse, psychosis. So it hasn't just got to be a bad thing. Post-traumatic stress, all of that stuff can result in feeling suicidal. Low self-esteem, alcohol, anxious, pressure from family and peers, feeling alone, PTSD, suicidal feelings in rare cases, and obviously medication. So SSRIs, antidepressants, can cause suicidal feelings in the first 2 weeks of taking antidepressants. So if you've got somebody who's had a change of medication and it's mental health medication, they are more at risk of suicide in the first 2 weeks of taking that new drug. Okay. They can build up over time. So suicidal feelings can build up over time. It doesn't just happen. It can build up. Self-harm can obviously lead into more suicidal thoughts and feelings. Not that people self-harm are suicidal. Suicidal feelings can get in the way of everything else. So it becomes much harder to live. The warning signs, so this is what we're looking for. It may not always be easy to spot these signs, but this is what you're going to be looking for. We're always thinking about death or talking about death. Depression and sadness, loneliness, increased trouble sleeping and eating. Now, we all know when we're hungry and tired, we have really terrible mental health. Feelings of helplessness and worthlessness, self-harm, feeling of angry, or they just can't explain the symptom. So again, if we think it, we ask it. What to do if you're feeling suicidal? So this is the self-help and the crisis plan. So if you've hurt yourself or you're thinking about you hurt yourself, you can call 999 or go straight to A&E. First step is to obviously to talk to somebody and make sure that you do that. Now, the problem with the Samaritans and other self-help groups, they're not there for counselling services. They're not going to tell you what to do. They're just there as a listening ear. What to do about those suicidal feelings? Sometimes talking about them helped. You can use grounding techniques. So grounding techniques is where we say to somebody, they could have a box, and in that box will have things that have protective characteristics to them. So it could be that they've got a teddy bear. It could be that they've got their partner's jumper or their mum and dad's jumper. It's anything to break that focus that's going on in their mind. So what we can do if we're working with people that have suicidal thoughts, a self-soothing box helps ground somebody. Grounding could be showing them pictures and images. It's just to stop that cycle going on in their brain. Okay, so a soothing box is really helpful. Focus on your senses. So concentrate on what you're hearing, what you're feeling, what you can taste. Getting them to talk out loud and break that internal voice. Tips for the long term. So if this is for someone that lives with suicidal thoughts, I think that's when to say think about things in your life that might making you feel stressed. So it's about managing those problems and teaching people resilient skills. Because again, they may not feel that there's any other way around. Speak to the GP about getting help, make that safety plan. And again, you can click on that link and it'll take you to a safety plan. And again, you can make a self-soothe box. Treatments for suicide. Having suicidal feelings can be really scary. It can be supported by your doctor, cognitive behavior therapy, the CBT, and other forms of therapy. So there is a therapy called DBT, dialect behavior therapy. And for DBT, that's where you make an agreement to keep yourself safe. And if you can't agree to keep yourself safe, you're not allowed to do therapy. Medication, again, the problem with medication is it can increase the risk of suicide. It's a bit of a bug of that one. You know, if you need the medication, it's prescribed, but the risk of the medication is increasing the risk of suicide. And it's important to find out what feels right for you. Suicide in young people, well, really in anyone, it's a very individualized thing. You know, what works for one isn't going to work for another. Confidentiality, obviously anything you tell your doctor or therapist is confidential unless otherwise puts other people at risk. So here, when we talk about suicide, once they've asked the question, are you feeling suicidal? You want to kill yourself? That's the first question we ask. The second question we ask is, are you going to harm anyone else? So there's a lot of evidence that suggests people that are feeling suicidal can also harm other people, because if you've hurt me in your life, if there's post-traumatic stress, or I want to even a score, if I'm feeling that I'm going to kill myself, then actually harming you, you know, there's no risk there. And that goes back to that example that I told you about the lady that I worked on the forensic ward. She killed her baby and then she went to kill herself. Nobody asked her, are you looking at harming somebody else? And obviously she killed her baby first. So it's really important to ask that as well. And obviously under confidentiality, you know full well, if you're going to harm somebody else, we have a duty to report it onwards. How can I tell if a friend is feeling suicidal? Again, no simple rule, you just have to ask. Look for changes in the behaviour, look about the conversations relating to death, look at their risks that they're taking. So are they taking lots of unnecessary risks? Are they taking substances and drugs? Are they taking part in dangerous activities? So this sudden behaviour into dangerous activities is that carefree behaviour. Or suddenly becoming calm after periods of distress. So that's that feeling okay now. Obviously, to support somebody, listen without judgment, stay calm, don't overreact. Be aware it's not your job to take the pain away. You can't stop somebody doing it. If they intend to do it, it's not on you. Okay, so it's really important you don't take this personally. Try not to downplay, brush it off. What you're looking for is them to encourage and open up to you, to talk to you about what they're thinking and feeling. Help them build up a wider support network. So again, that could be the charities, Samaritan's Childline, Young Minds, IASIS, I think it's called, INI 111, 909. The more support networks you've got, the safer your plan is. Okay, and that's because if I'm feeling suicidal, I might ring the Samaritans and they can't pick up. I might try Childline or the next one. So the more options you give somebody, the safer that plan is. So don't give somebody one or two options. Really do your homework. What's in your area? There's lots of charities, and there's different charities for men, different charities for women, different charities for children. If somebody says to you they're suicidal, again, it's not a one charity fits all. Find the right charity for them. And obviously make sure you talk to somebody as well. So make sure you offload. Does telling an adult my friend is suicidal make me a bad friend? It's obviously difficult to talk about. Again, it's not your responsibility. It doesn't necessarily make you a bad friend. You know, if you're looking for help and support, obviously there's that confidentiality thing, and if you break that, you don't want to be the one that's done that. But obviously, just think about what it is you're going to say to them. What can I do if my friend doesn't want to, let's say, talk about it? Again, if people find it difficult to talk, you can talk to them. You can talk about different helplines. You can talk about different options. You can leave literature. you can leave fact sheets, you can leave safety plans, you can leave crisis cards. You know, you can take a horse to water, but again, you want them to kind of be able to follow that. Where to get help? So Samaritans is great. There's Young Minds. For carers, you've got access to, I think it's called Shout. So if you type Shout on your phone, you get a text back, and it's for care workers. It was originally an app for NHS workers, and then because of COVID, they opened it up to all health and social care workers. So if you type Shout because you're feeling suicidal, you get a response back straight away. Are you in a safe place? And there's another one called Wazoo. It's a penguin, and again, will give you a safety plan. Texts from a lot of your mobile phones are free for suicidal helplines. Childline, up to 19 years old. They obviously do counselling, have access to interpreters and all of that lot. And Calm is the campaign against living miserably. So again, they've got lots of free stuff. The sad thing is, there's more stuff for younger people than what there is for working age adults. You know, it's great that we've got all of this stuff for young people, but again, there does seem to be an inequality here, because actually anyone of any age can feel suicidal. This is the Pyrasis one, Pyrasis, again, another confidential helpline. Mixed to support anyone under the age of 25, sorry. Okay, so for you, understand the ways of preventing suicide. So you need to ways of looking at reducing things that contribute to suicide, interventions, increasing the safety of the person, and helping the person who's injured or affected. So meeting the needs of the person at risk for assistance in their life. First steps, identify interventions to discuss suicide. So this is just us talking. Are you planning to end your life? Connect with them, explore and ask. So that's the very first step. That's what you're going to do. The second step is listen to their story. Why are you feeling suicidal? What has brought you to this point? Because again, listening to this, what you're looking for are those turning points. Now, what a turning point is, it's a protective factor. It's something that grounds somebody. So, for example, a protective factor might be, you know, I've got a loving mother and father. Okay, so if I'm talking to you and I'm saying to you, look, I'm just going to end it. I just can't cope. You know, I've got my mum and my dad. They love me dearly. That's a turning point, because I've given you something positive. It's your job then to pick up on that and just say to me, well, look, tell me about your mum and dad. Because what you're trying to do is ground me and keep me in the now. And equally, understand their choices and make sure you've heard them. If you've got some turning points, if you've got those protective factors, if you've got the things that you think, look, I don't think you're going to do this, then we can agree a safety plan and the actions, and we can say, look, you agree to keep yourself safe. You agree that if you're feeling suicidal, you're going to go to the hospital. Do you agree to call an ambulance? Do you agree to ring me if you're going to do something? And I go, yes. And we've agreed a safety plan. If I say no, then we can't move to the third step. Okay. So at this point, you'll just hear me. And if I keep saying no, then you're going to call the ambulance and just keep me talking until the ambulance arrives. If you're thinking, look, I think this is Steve just having a meltdown, we can agree the safety plan. You can assist in life. So, for example, remind me about those protective characteristics, develop that safety plan, and obviously just make sure that you confirm that with me. So, look, Steve, you've agreed that you're going to go to hospital. You've agreed that you're going to do this. You've agreed that you're going to do that. You've agreed that you're going to call me in the next half an hour, whatever it's going to be. We agreed that suicide is our focus. So is that now on or off the table? Are you still suicidal? Are you not suicidal? We've agreed that safety is our focus. So you've agreed to keep safe. You've not agreed to keep safe. Or we've agreed that we're able to keep you safe for now. So in other words, you're not going to do this in front of me. Again, looking for those weapons and stuff. We need to understand invitations. So we need to look at what they're telling us and what we're seeing. So again, we're looking for the actions. Are they showing us stuff? Are they trying to give us things? Or physical, you know, are they starting to tell us things that's going to make it a lot more harder? So lack of sleep, angry, depressed, etc. We'll explore those invitations. So again, is there a risk there? Is there not a risk there? Reasons to ask directly about suicide. So again, you want to know the answer. Say you don't think badly of the person. Clearly state that suicide needs to be addressed. So we're not going to not address it. I'm going to ask you until you've given me the answer. And if the person is not thinking about suicide, all it shows is that you care. Okay? So there's no evidence that says asking somebody until you get the answer puts them at risk. Showing that you hear their story, you can use these phrases for you to do that active listening. So you feel you can just live in this pain. From all you can see, you've got no good or any more. There's no way you feel you can focus on the situation. You just want to get this turmoil over with. It feels like hope is a thing of the past, or you're thinking let fate decide if you live or die. So that's you just using active listening skills. Whatever they're telling you, you're just going to repeat back. Like we said, you're going to be looking for those turning points. What you're hoping for is that they're going to reject suicide. So in other words, they don't want to do it anymore. Look, I thought about it actually after talking to you. I'm fine. You know, I haven't got any plans here. Hope for something. So you've got some of those protective characteristics. So for example, look, maybe you've grabbed me and I say, look, get me somebody to talk to. I talk to them, that makes me feel better. If I'm uncertain about my choice, you can say things like, so what I'm hearing is you don't really want to do it. You know, so again, we're just looking for those turning points to take them away from suicide. Or finally, at least you're willing to try. And again, that's about them keeping themselves safe. So you're willing to try and keep yourself safe. So as we're talking to somebody, we're just looking for those protective characteristics. We're looking for something to think, actually, you're not going to do this. Signs, then, we've already covered. Again, just to recover it because it's important. Extreme moods, feelings of hopelessness, giving away possessions, loss of interest in activities, talking about death or suicide, saying goodbye to friends and family, saying that they're a burden, or being withdrawn. Don't discount their feelings. So obviously just make sure that we're still talking. Look at suicide. Obviously don't look at suicide as a cry for help. Don't say to them, you know, it's a cry for help. That's not helpful. When a person attempts suicide, it isn't necessarily a sign that they want to die. It's just the fact that they're in that so much emotional pain. And that's what I was saying. When interviewed, 95% of the people that have attempted suicide didn't want to die. So it gives you an idea about all of those people that have died and they still want to live. Obviously, be a good listener. Just be that active listener. Encourage them to get help. That's that signposting. And ask about their feelings. So don't be afraid to bring up topics. You know, just talk to them as if they're a normal person. If you feel that they are and they don't agree to that plan, obviously don't leave them alone. Call the 999 or use their safety plan if they have one. So if you've never seen the safety plan, like I've said, you can download them from Mind or Rethink. Obviously encourage them to see a professional. That's your on thing. And know that secrets can kill. So you're not going to say that you can keep this a secret. You're obviously going to support them. First aid principles then is ELGI. So if you've done Mental Health First Aid England, you've got this as your acronym. So approach, assess and assist, listen, communicate non-judgmentally, give supported information, encourage professional help and encourage other people to support. So that's your first aid principles. It's a bit like Dr. ABC, it's a bit like primary and secondary surveys. So that's your first aid principles there. Okay, so any questions on suicide? No? Shall we then stop now for a quick break and come back for 1:15? What's the time?
15:01.
Okay, so 15. Right, yes, if we come back for 1:15, is that okay?
Yeah.
Lovely.
Mm.